at this moment in time, we are probably at half capacity in our COVID ICU. And then we still have our regular ICU where we are having, the normal ebb and flow that you would have during the winter seasons.
So I want to stop you there for a minute, because the normal influx in a winter season. Now, I have worked when I used to work in the hospitals. I did like a PD med surge floor, and every winter we would get overwhelmed. Now, I haven't been in the hospital in years. So even years ago, when I worked in the hospital, we would open up another unit because like the pediatric med surge floors would get so overwhelmed. We'd have pneumonias, bronchitis, RSV, just really sick kids. And then I would, like you, open up another unit, and then we take the overflow. And then when things calm down, we shut it down. And then also in the past, when I worked in ERs, we used to go on what's called diversion. So we would just have so many patients that the doctors would actually say, we're on diversion. We wouldn't take any more patients, and they would ship them to the next local hospital. And I remember, those hospitals used to get mad, oh, they're on diversion, we're on diversion. But that is a normal situation that happens in hospitals all the time, especially during the flu season or the winters. Could you just verify what's going on? Because I know I haven't been in the hospital in a long time, but that is the normal influx for the winter. That is still the norm, correct?
Oh, 1,000,000%. Yes.
And right now, we're just going to stay with this for a minute. Right now, is it worse than a normal season, like as of today?
No, so my 11 years working at the bedside, 10 in the ICU, it is not any different than it has been in previous years. The caveat to that, however, is respiratory, winter, you think of respiratory, you think, lots of pneumonias, like you said, bronchitis, flu, all of the things that would essentially affect your lungs. Funnily, the flu is essentially non-existent. I have yet to take care of a flu patient in the ICU.
Now, does that mean you're not testing them, or are they just not coming in for the flu?
I think it's a combination, but I think it's definitely more so. So at the facility that we have a 3-in-1 PCR. So it tests for flu A, B, and COVID. So that was new as of a couple of weeks ago. Okay. So prior to that, I would have these patients that get admitted for respiratory issues, would test negative for COVID, but they wouldn't believe the negative test. And funnily enough, we would believe all the positives, but if it was a negative and they came in with respiratory anything, they're like, no, it has to be a false negative. So we would test over and over until they essentially, got what they wanted out of it, which would be a positive COVID test. But yeah, no, just the flu is, back to that patient. I asked, one of the residents was like, can we, test for flu with this patient? He tested negative for COVID. He interestingly enough, got the flu vaccine 2 weeks prior to coming into the hospital, and then started having all these respiratory issues. And, the resident was a little snippy and was like, well, we're not technically in flu season. And mind you, this was already in November. And I said, what do you mean we're not in flu season? Tale as old as time, we started inoculating in September. There's no reason why we always test for flu at this time. And he just kind of gave me this spiel about, the CDC and the WHO. And I was like, well, forgive me for not having the utmost confidence in them at this moment in time. I go, however, we're treating him for a respiratory illness. COVID is negative. Let's just humor me and let's just do flu. Funnily, it did not come back positive. Flu was negative again, but regardless, just flu is just, it's ridiculous. We don't have a flu case on our unit. I haven't seen one, and I've been asking, and I've been just kind of poking around just to see if I could find one, and I still can't find one. So it's just very interesting to see, the dynamic shift, with COVID, and everything is COVID. COVID. It doesn't matter what you are. Everybody that gets admitted to the hospital gets a COVID test. It's just very funny to see how we're doing things right now in the medical system, in the hospital system. It's just very, very interesting to see the shift from the way we've always done it, tale as old as time in the winter, to now COVID everything. It doesn't matter. We're doing this COVID. It's just been very interesting to see, to say.
What is the treatment for COVID right now?
So at this moment in time, we're still doing remdesivir, and then
that's newer for you guys, right?
Correct, it is.
Yeah. Is that one,
So when
is that emergency use authorization, or is that one actually approved? Do you know?
I don't know, to be quite honest. I really don't. But it's remdesivir and then the systemic steroids. So everybody gets high dose IV steroids. And then they do the vitamin C and the zinc as well. The cocktail.
Is it infusion vitamin C?
No, it's PO or oral, excuse me.
Well, that's new. Is that new?
Yeah, it is actually. It's very, very new.
Well, that's reassuring.
And that's new. It is. But, then the more you read about it, especially with, supplements and stuff, you really have to see where they're coming from and what they're, being formulated with, because if they're being formulated with a bunch of, chemicals, essentially, it just kind of null and voids the vitamin aspect of it, or, the mineral aspect of it. It just doesn't really, it cancels each other out, if you will. So just lots of learning, but it is reassuring that they are doing that. But when we first started treating, it was the hydroxychloroquine. We were doing that, and that didn't stick around for very long.
Were they doing okay with that?
No, at that point, we really didn't have a great grasp on what we were doing.
Right.
And
that's supposed
so
to be,
were,
that's a pill, and that's not really for the later stages when you get into the ICU.
Right,
right,
definitely, yes. So a lot of our intensivists, they did that because that was the initial treatment, and then they got away from that, and then we started doing convalescent plasma, and then we're not really doing that a whole lot right now. It's just more the remdesivir is very specific to our COVID patients at the moment in time.
And how are they doing? Are they surviving?
We're having, it really just depends. A lot of the patients that do go on ventilators, they get trached. We have had, instances where they do get decannulated before they leave the hospital, but that's months after they, initially presented. So their stays are very long. Now being like the last maybe 6 to 8 weeks, they have a little bit better handle on what we're doing versus, March, when everything kind of first started. So it's, at the moment in time, I think the last time I checked in our hospital, we had, I think it was like 140 something deaths. There's a hotline that you can call specific to our hospital. That's not a whole lot of deaths considering, the way that they show things to be, out in the public. And the hospital that I work at, it is, a very large facility. So.
And another question, do most of the people who don't do well have comorbidities or pre-existing conditions?
100%. It's 100% across the board of any individual that comes to our ICU. They all have comorbidities, every single one of them.
And are they older with the COVID?
So I have seen anywhere, the range is very broad, from 24, I believe, is the youngest that I have. Well, no, I take that back. I had a 17-year-old the other day, to, 80 something, mid 80s. So it's very broad, the range. So, but the individuals that don't do so well are typically between probably like the 40 to 65 range. Those are usually the individuals that are
with the comorbidities and pre-existing conditions.
Correct.
Yeah.
Correct. Yes.
How are you keeping yourself protected?
So, definitely, eating right, your mental health.
True nurse right there. Eating right. The first response.
Eating right. Oh yeah. Yes. Eating right. That is the marker to, essentially anything.
Right.
If you don't have a good diet, if you, of course, don't get that exercise and that sunshine and, just going outside and being active. I mean, those are things that, when we were in school, we had an itty bitty little book on nutrition. I mean, it was super tiny, but we had an entire class on medication, on, pharmacology.
Right.
So it's just, it's been essentially shoved down our throats the way we practice medicine. I mean, the American Medical Association was founded by the Rockefellers, who also have, stock in, big pharma. So, I mean, it's very, very, very one-sided treatments. So, it's just very interesting. The things that I've learned this year from the things that I learned in school, it's just been very interesting. You have to definitely go off, the beaten path, and figure out a lot of things on your own. Because you'll never be told that in the schooling that we go through.
We hope that changes, but we haven't seen that. Does anybody
say they are doing a lot of like D-dimers and focusing on like blood thinning? They do Decadron, and she said that they are doing as much as possible to keep sending the patients to the ICU. So they are doing high flow oxygen. She's saying she's never even like done such high flow oxygen on the standard floors. It's different because you are in the ICU, so you're getting them there. But do you have any kind of knowledge of, are people going home, or are they, from the general floors? Or are they all kind of being intubated still and ending up in the ICU?
So it's hard to say who's going home, just because, once they get out of the ICU, unless they come back, I don't really know kind of what happens. It's more kind of secondhand hearsay from our physicians, et cetera. So I do know that we are sending a lot more people home now than we were prior to. Our intensivists, so they, kind of alternate in the ICU, and then on the regular floors, they're also pulmonologists. So they do their ICU stent with the residents, and then they, after they do their week in ICU, then they'll rotate out to the regular floor. So a lot of the information that I'll hear about decannulation from the trachs and patients going home come from just hearing their conversations, one, asking them, and two, hearing their conversations with other, physicians that inquire throughout the hospital. So I do know that we are sending more people home and decannulating their trachs. So that is a good thing from prior to when we first started. I will say that our physicians have been very diligent about not putting individuals on the ventilators. They have been allowing people to have oxygen saturations in the 60s and 70s, breathing 40 to 50 times a minute on a high flow with a BiPAP or whatever, just to make sure that they do everything, and allowing them to stay like that for days. I've seen an individual like that for weeks,
Wow.
Yes, but they make sure that they really do try not to put people on the ventilators. I will definitely say that about our hospital, that they have been very diligent about that. People that we would typically respiratory distress, they're breathing in the 40s and 50s, oxygen's in the mid to high 80s. Obvious distress, let's just go ahead and intubate them. But with the COVID population specifically, that is something that they have not been doing. So it has been very, uplifting in that sense, that they are, following that guideline.
Good.
But yeah.
I have a question about the visitors, family. I know ICU, obviously is strict anyway, but what is it like during COVID and now?
Yeah, so that's a hard one. So we did go through a period of time where we had no visitors. There was nobody allowed to come up. Specifically in our COVID ICU, they don't allow, the way they have it sealed off, if you will, is only the individuals that are working and the patients can go in there. So there's no foot traffic from family or anything like that. just because of the precautions that they take for the COVID patients. But even up in the regular ICU and just for the hospital by itself, there was a time where they stopped having families go up there. And that was really hard because patients that have nothing to do with COVID, I took care of some, that are passing or we're withdrawing on, and they only allow a certain number of family members to be at their bedside. And I mean, I couldn't imagine somebody telling me that I couldn't come to see my loved one pass away when they made the decision to withdraw, or if they died within their care for whatever reason. So that's been hard, and that's been a struggle. They do iPads for like FaceTimes and stuff like that. So that has helped. We did open up for a period of time, but now we've shut back down. So it's been hard having people that are passing away, or not even just passing away, just needing that, family connection, touch, what have you, advocation essentially for their loved ones, and having them not there because they don't know what's going on, or they can't see what's going on because of measures that have been in play or enforced upon us to implement to the public that, I mean, in a lot of people's opinions, just are not the best quality of care that we can give to our patients. So it's been interesting to see that too.
You've been a nurse for over a decade. You've done mostly bedside care, mostly ICU. You've taken care of a lot of contagious patients, I'm assuming.
Yes.
In and out of rooms, PPE, taking care of other patients. Does this virus justify the lockdowns, shutting down of businesses, the forced vaccines, not visiting your loved ones, shutting down Thanksgiving, Christmas? Does it justify this? And, what are your feeling on that?
So taking my personal opinions out of the equation, just in the scope of medicine, I do not feel like it does. I worked Ebola. Ebola is highly contagious. I have seen things that, warranted intervention from government officials, et cetera, such as, the implementations of certain things that they've been doing with COVID. And if we listen to the government, which I don't know why government is trying to dictate science, but if we listen to them and listen to the things that they say, people should just be dropping like flies on the sidewalk. And, everybody should have the same story of my loved one died from COVID, or my friend died from COVID. That's just not the case. That's not what we're seeing. That's not the patient population that we're having. Yes, is COVID real? Yes, 1,000,000%. I believe it's real. But it's not any worse than anything that we've seen. And I've actually seen and worked a lot more contagious disease processes than COVID at the moment in time, which begs to question, why are they doing this? It's hard to believe that it's for the public and for the wellness of, individuals, when it's so far from that, with, child homicides, suicides going up, cancer patients still dying, cardiovascular health, diabetes, all of these other things that are so much more prevalent and relevant in our time. And there's no spotlight being shown on any of those. It's only being shown on COVID. And it's just, it doesn't deserve any of the hype that it's currently getting. There's so many other things, every life matters, COVID life matters, but, everything else is being pushed to the back, and that's not fair to anybody. So I think it's doing more harm than good. I don't see the benefit at all. And if it was beneficial, and if it really was as bad as everybody's trying to make it out to be, then 1,000,000% I would be advocating for it. And I would say, yes, you're silly to not do this. You're silly to not, mask up, which masks are ridiculous in and of itself. I remember when we first saw the CDC guideline for masks, one of the main intensivists, and I quote, said, the CDC needs to take that off of their website. with the bandana, I think it was specifically that they were pushing to the public in the very beginning. He said they need to take that off their website. I don't even know why they would put that up. And now it's Bible. They're like, oh yes, if you don't have a mask covering.
Oh,
I'm like,
really?
what are you talking about?
Interesting.
I'm like, in the beginning of all of this, you said, why do they even have that up? And now it's, yes, why would you not wear a mask? So it's just, it's been interesting seeing the tide, kind of sway to the other side, especially when they were so adamant on, no, that's not what we should be doing. And that's not the information we should be spreading to the public. And now everybody is, Bible, mask this and social distancing that. So it's very disheartening to see it, because we're not in the profession of hurting, we're in the profession of helping. And when you see that there is an ulterior agenda, obviously, I mean, it's so, in your face, it's very hard to, turn away from it, that it's just so, it's very disheartening to see a lot of the things that are going on currently in the health system.
I appreciate all of your input. Thank you for
Of course, thank
taking
you.